This is the last recording for chapter 27. So, injuries of the ear, because the ear is pretty complex and has so much going on inside of it, um, it depends on what part is damaged as to what you're going to see. So, it can deal with the hearing or balance or both. The ear, remember, is divided into three parts. We have the external ear. I'll just go over the picture. External ear, which has the pin or the auricle, which is mostly made of cartilage. Generally not going to be a huge issue. That goes all the way into the tympanic membrane, which can be injured relatively easily. You have the middle ear, which is all of those little ossicles or those bones. And then you have the inner ear, which actually has all of the sensory organs for balance, proprioception, and hearing itself. When ears are injured, they often don't bleed very much. There's just not a whole lot of um, blood vessels that are there. So oftentimes just a roller gauze or just a little bit of pressure can actually stop the bleeding pretty good. In case of an ear avulsion where it's kind of torn off, either fully or partially, put it in a moist, sterile dressing, and then if it's been completely avulsed, torn off, go ahead and put it in a plastic bag with their name attached to it. We're not putting water in the bag though. Like we're not submerging the part. Your tympanic membrane, if it ruptures, this can be caused by like a sudden change in pressure, um, or it can be from direct injury, people sticking Q-tips too far in, something along those lines. Um, Signs and symptoms, the pain tends to be pretty severe. You may or may not have bleeding. Some hearing loss is expected, but it kind of depends on the extent of the injury. And there's really not a whole lot of management for us in the field that we're going to do with it. Kids love to put stuff in their ears and noses, love to put stuff in there. So if they do get something stuck in, we're not going to try and move it around or try and take it out because we could actually push it in even further. So typically we're just going to let it ride out um, and let the doctor take it out. Be aware that any clear fluid coming from the ear may indicate a skull fracture. It doesn't always indicate a skull fracture because it can be from an infection that has ruptured the eardrum, etc. But if we see fluid, we should be more concerned than normal. Facial fractures are typically because of blunt force. Um, if a patient has sustained a direct blow to the mouth or nose, it's more than likely that they have a facial fracture. It may be stable and you can't actually find it. There's just localized pain, pain, swelling, and tenderness in that area. Typically not going to be a big emergency unless there's serious bleeding. You do have the possibility of upper airway obstruction if they're bleeding internally. Signs and symptoms mostly is just going to be pain, tenderness, swelling, maybe some discoloration at the site of the fracture. There's often not a lot of displacement unless you have a large area affected. Plastic surgeons are going to be required to repair the damage if the patient gets in within 7 to 10 days. After that, it becomes a lot harder. We want to remove and save any loose teeth or bone fragments because it's often possible to repair them. We want to remove any loose dentures or dental bridges to protect against airway obstruction. Now remember, loose is the key word on that. We're not yanking a palate expander out of the top of someone's mouth. Like if it's in there and it's secure, it can stay. But if it's bouncing around, then that could be an issue. We really need to be cautious about the fact that swelling can become pretty extreme within the first 24 hours after the injury. So maybe somebody, fell out of a tree, smacked their face, whatever, thought that they were okay. And now here they're calling, um, a day later because they have all of this pain and they can't deal with it and they have all of this swelling. So it is possible for us to have a patient, after that initial trauma. People try to walk it off an awful lot. Dental injuries, they can be really traumatic for a patient just because they worry about the permanent disfigurement of having one of their permanent teeth knocked out. Kids tend to freak out really quickly, but oftentimes it's not as bad because we know it's going to grow back with them. Bleeding will occur whenever you have a tooth that's taken out of the socket violently. We're going to apply direct pressure to the bleeding, perform suctioning as needed, and then make sure that you get the teeth or the pieces of the tooth out of the mouth so that they're not an airway obstruction. You can still bring the teeth with you. If it's just a piece, they're probably not going to be able to do anything with it, but a legitimate tooth that's gotten knocked out, go ahead and bring it along with the patient. They may actually be able to put it back in. Management is more going to be reassurance, talking down the patient, rather than actually treating. Injuries to the cheek, you may encounter an impale object within the cheek. If you can't control the bleeding, or if you can't truly deal with the airway itself, or you're worried that it's going to become occluded, go ahead and remove the object. Otherwise, you can leave it in place. If they're doing okay and the bleeding's not overwhelming, like, leave it there. You can provide direct pressure on the inside and outside of the cheek, and make sure that when you bandage that you don't actually block the airway. We don't want to make it difficult for the patient to breathe, especially if the bleeding is relatively minor. Injuries of the neck. The neck contains a lot of structures. It's very vulnerable to trauma because our head is actually pretty heavy and our muscles don't hold it super still when there's a lot of force applied. Blunt injuries, any crushing injury to the upper neck is likely to involve like the larynx or the trachea. They are cartilages, they are relatively strong, but if they are fractured, they actually are legitimately broken, they are not going to move back into their normal position. So oftentimes a lot of signs and symptoms associated can be hoarseness, trouble breathing, swelling, obvious deformity, that sort of thing. Management, there's not a whole lot we can do except for airway control. And keep in mind, if they have that hard of a blow to the front of their neck, they very well may have a C-spine injury as well. So make sure that you're taking care of that. Penetrating injuries, there's a lot of massive vessels. There's a lot of blood flow going on either side of your neck. And so penetrating injuries to the neck often are going to have profuse bleeding. It can actually cause the patient to exsanguinate or bleed out. I know you've probably heard that term from me because that's actually one of my favorite words. But if they don't, even an injury, minor injury to either the carotid or the jugular can result in an air embolism, which can cause long-term damage, unfortunately. And then you also have your trachea, you have your esophagus, spinal cord, all pretty important structures right there. For laryngeal injuries, this occurs mostly from blunt force trauma. Unrestrained driver hits the steering wheel, somebody that's got handlebars, such as a snowmobiler, four-wheeler rider ends up striking a clothesline or a fixed wire. And again, if the larynx has a crush injury, it's very likely that there's more injury than what you can see. Anytime that you think that there's or have an injury to the larynx, just automatically think that there's probably an injury to the cervical spine. If you have a penetrating or impaled object in the larynx, leave it there unless it interferes with CPR or your ability to properly secure the airway. Oftentimes, your laryngeal injuries are going to pose a pretty big threat for airway. It's definitely going to compromise. So just be very cautious about what you do. If you need to, occlusive dressings should be placed. If there's any possible risk of air getting in somewhere that it's not supposed to, especially when it's dealing with the uh, from the top of the neck to just under the rib cage. Management, transport, a lot of it's going to be oxygen, control the airway, and rapid transport. So that is the end of chapter 27.